I'm Joseph Figueras. I'm the Director of European Observatory, and I'd like to introduce my co-moderator. We'll have a double act. We're going to be improvising with Natasha Zopardi-Muscat, Director of the Country Health Systems at the WHO. And indeed, this session is organized between the WHO, Regional Office for Europe, and the European Observatory. If you haven't realized it, the title of the session is Time to Place Health Workforce at the Center Stage. I mean, this is one that doesn't need an introduction, really. It's just a pleasure for me to speak, but really, we've been talking about that so much and so long. The usual. The COVID has worsened a situation which was bad enough. The pressures on the work pressures, the mental health issues, been talked a lot. Yesterday was an excellent session discussing the issues of mental health in the health workforce, which worsened the long-standing problems of the health workforce. The shortages, the aging, the increasing work pressures, insufficient pay for lots of pain, and the brain drain, and many others. What we want today, and we haven't discussed that actually, Natasha, but we will disagree perhaps. We don't want you to moan, or we'll only allow Thomas to moan today. Thomas will tell us how bad is the situation, give us the numbers and the problems. But we don't want to hear the problems. We really, really, really know the problems, okay? We studied them ad nauseam. You can say a little bit about the problems, but just a tiny bit. We want to hear what we do about that. What are the kinds of priority actions? What are the politics of it all? Because some of these strategies, we've been publishing them for years as well. So is it politics? How do we address that? We know how severe it is. We know that there's life and death, and we will be seeing almost literally for our patients that cannot access our health services, literally for that. But we want to hear the practical way to go about that. We have two sessions within this session. The first, we'll hear about the WHO report, which has done an extremely good job, presented to the regional committee. Well, Natasha will say more about that because she is leading this area in WHO. And it was presented to the regional committee of WHO, which will tell us a bit the situation and some of the priority actions that we'll use for the discussion. Then we'll hear on the lessons from COVID. The practical lessons, what we learn about COVID that we can implement to address what's a really enormous challenge. And then that's going to be from the work of the Observatory with the WHO European Commission. We had this platform, the COVID Monitor, where we collected all sorts of policies at different levels of the health system. And indeed, we looked a lot at the area of health workforce. And finally, we'll hear the reaction of the profession. And then the second session will be, this is all about this one core element of this conference, is about the role of the European Health Union. Can the European Health Union make a difference? What new action should be put in place? So I think that's exactly what I wanted to say. Now I need to pass it to Natasha that will introduce properly this session.
Well done, Giuseppe. I think we're off to a fiery start, in spite of the very dark and grey Gastein weather that we have today, but it's good because it keeps the people inside and busy with us in the sessions. So thank you very much to all of you for joining us, and thanks also to all those people out there online who are also joining us, and we want to make sure that this is your session and we would like it to be as interactive as possible. So for those of you in the room, beware, because Giuseppe has this nasty habit of walking around with a microphone in his hand, and unless we get questions and comments from the floor, he will just, pick some unsuspecting individuals. So think about what you want to ask and what you'd like to share. For those of you who are joining remotely, I'd like to introduce our colleague Chris Cotter, who will be monitoring Slido for your comments, questions, responses, and everything can be submitted on Slido. And he will, from time to time, tell us and bring into the room your observations and comments. And then also, we will have some interactive Slido. So for those online and for those in the room, please make sure that you go to slido.com and either use the hashtag Luna, you see that over there, or scan the QR code. So you can get your phones ready. It won't be for a while, but towards the end of Thomas's presentation, we will ask you to become engaged and involved. So I think Giuseppe said that, of course, the health workforce is a key issue. A year ago, I told Thomas, I said, look, we know that every single minister is coming to our regional director and saying, I can't sleep at night because I'm so worried about our health workforce in the midst of the pandemic, and then with the emergency and conflict situation. Really, our health workers are totally overstretched. And I challenged Thomas to produce a report that would cover what we have and what we know, and more importantly, what we don't know and what we need to know about the 53 countries in the region. And I always thought that I know this area, and I know it well, and I've written about it, and I set up a section when I was president of UFA because it's so important to me. But when I was reading through the report, I realized that there were a lot of things, actually, that I did not know. And that when you start to see them, black and white or in color, and you start to see the trends that are prevalent in the region, the differences between countries, production capacity, dependence on foreign workers, the starting point is really to present the data, and this is what Thomas will do. In a second, let me thank Thomas and his team and all the partners from the Observatory, Matthias and Gemma, from OECD and from DG Santé, who have really contributed to pull this report together. We would not have been able to do it as WHO on our own. So it's my pleasure to introduce my colleague, Thomas Zapata, who is the Regional Advisor for Health Service Delivery and Workforce, because there is no health service delivery without the workforce, to introduce the report. Over to you, Thomas.
Thank you so much, Natasha and Giuseppe. And in these 7 minutes, I'm going to give you a flavor of the report. It's available hard copies outside, but you also have the soft copies. So the report is Health and Care Workforce in Europe, Time to Act. And I'm going to try to defend why this is an urgency and why it's time to act in Europe. This report is the first report on health workforce in the pan-European region, in the 53 countries. It comes with presenting some effective policy and planning responses to the current challenges that we face on health workforce. And it also comes with 10 proposed action points for the way forward, to really position health workforce on the way forward. It focuses in 6 health professional categories: doctors, nurses, midwives, dentists, pharmacists, and physiotherapists. There are many more that we are missing, we are aware of that, but we take this as a starting point. Our intention is that progressively we'll be able to support countries in strengthening their HRH information systems, and so that we are able to collect and countries report more and better data to us so that we can present a more comprehensive picture. This, as you can see, the report also contains 53 country profiles containing data on availability of health workers, doctors-nurses ratio, in terms of numbers, in terms of gender distribution, age distribution, in terms of migration and a little bit on production that we have at the moment. And the data comes from the National Health Workforce Accounts, and it has been reported by countries through the joint data collection questionnaire that we have jointly with WHO, OECD, and Eurostat. So, since we launched the report 10 days ago in the regional committee, I think we are getting quite a lot of attention from the media, basically on the aging side in different newspapers across the region, Brussels, Politico, and we have quite some others. So I think the topic is really relevant and is capturing a lot of attention at the different countries. Just to give you a snapshot of some of the findings, this is just very few. I really encourage you to go to the report. The first message is that there are substantial inequalities in the availability of health workers across the region, and especially for nurses. As you can see here, there is 9 times difference between the country with the lowest density of nurses and the country with the highest density of nurses. If we look at the sub-regional distribution, we see how Western Europe has 3 times higher density of nurses than Western Asia. And if we look at doctors, Western Europe has 2 times higher density of doctors than Central Asia. So big disparities. The second key message here is that we have an aging health workforce, and especially for medical doctors. 1 in 3 countries in the region, at least 40% of the doctors are over 55 years of age. This means that in 10 years' time, more than 40% of the doctors in these countries will be retiring. And this is a huge crisis that we have in front of us and that is coming. We have seen during the COVID pandemic how the major cause of disruption of services and generation of backlogs and waiting lists has been shortage of health workers. So in addition to that, we have this huge aging workforce that is coming. So that requires that we start acting now, that countries start planning right now the future health workforce. Otherwise, it's going to be too late. And that's why time to act at the title. Gender distribution. What we see is that for the last 10 years, female doctors have increased from 43% to 48%. And still, we see very high proportion of nurses being women, 89%, and 98% of midwives being women. So we have a highly feminized health workforce, and we need to take this into account when developing policies and taking policy decision-making forward. It's something that needs to be taken into consideration. Next, the last graph that I want to present is on the production of health workers. We have seen a significant increase in the production of health workers, but we still see a high variability in that production. So for example, for doctors, in the last 10 years, there has been a 37% increase in the production of graduates per 100,000 population of doctors, 26% for nurses, and 29% for midwives. But still, we see a big difference between those countries with lower production and higher production. Although we see that those with a small production are mainly small countries, we should also need to look at the country context. And I want to finalize with these 10 action points that you will see in the report. And the action points go from improving education, continuous professional development, in terms of improving retention of health workers, health and well-being, governance and planning. You will see all this. But what we want from you now is that if you can access the Slido, as Natasha mentioned, you will see the QR code and the password, Luna. If you can access the Slido and prioritize the top 3 out of these 10, which ones are for you the top 3 priority actions in the region, on your countries or for your organizations. So if you can get into a Slido and start reading these 10 actions and prioritize those 3. And just to conclude, I wanted to reinforce the huge teamwork that has been here under the leadership of Natasha, working closely with the Observatory, with the European Commission, DG Santé, OECD, and many other co-authors of the report. So thank you so much for the whole team, and thank you, Natasha.
Thank you very much, and I think it goes without saying, you can see for yourselves that we really have Thomas leading very competently and passionately in this area, and as WHO we are committed not only to put it on the agenda, which I think we've done very well. It was across the headlines last week of most major newspapers, but we now need to get it, with your help, into the universities, medical schools, regulatory councils, professional associations, because far too often these actors themselves are even missing some pieces of the puzzle. So we rely on you also to help us get these findings to those people who need them in order to take the informed decisions. And of course, the COVID pandemic was an eye-opener. I like to say, or I used to like to say about a year ago, that COVID has unmasked many of the problems with the health system. And indeed, I think we know that the health workforce was already in a difficult situation in the European region before COVID, because of underfunding, because of undertraining, because of underinvestment, because of under-recognition. But COVID, of course, by harshly pulling away this mask, then showed us the reality. But as our regional director always likes to say, the COVID pandemic has shown us the fragilities, but also the strengths of our health and care workforce across the region. And in order to tell us a little bit more about this, I'd like to give the floor to Gemma Williams. Gemma, who has been working closely with us in this area throughout COVID from the European Observatory on Health Systems and Policies. Gemma, over to you.
All right, thank you very much, Natasha, and thank you, Thomas, for giving us an impossible task of choosing between those action points. Yes, I think Natasha has set this presentation up really nicely, because I think absolutely no one in this room needs me to tell you how challenging the pandemic has been for the health workforce. But at the same time, we have a huge opportunity if we sort of take time to sort of learn from some of the reforms that countries put into place for the healthcare and workforce to make sure they could meet the demands of the pandemic. So we've seen across the region a huge range of actions were put into place to make sure that the health and care workforce could respond to COVID-19. So to create surge capacity, we saw numerous actions put into place. They targeted sort of the existing workforce to maintain capacity. We saw students being allowed to graduate early. We saw volunteers being brought in. We saw retired and otherwise inactive workers being brought back into the workforce. Reforms were implemented to make sure that people didn't retire and that they stayed on to help throughout the pandemic. But creating surge capacity isn't just about increasing numbers. It was also about repurposing and reskilling the workforce. So we saw a huge increase in the use of digital technologies. We saw the training as well to make sure that health workers could use these digital technologies. We saw skill mix innovations coming into play. So we saw health professionals taking on new tasks. So pharmacists were able to sort of renew prescriptions for chronic diseases in a lot of countries that they hadn't been allowed to do before. In the area of vaccines, really, we saw lots of task sharing, so dentists, nurses, pharmacists could vaccinate, which they hadn't been able to do before. And then we saw lots of action in the area of retaining, protecting, and supporting health workers. So lots of countries gave bonuses or they increased salaries for healthcare workers, perhaps in recognition that they weren't paid enough before. We saw lots of support for mental health, but perhaps not enough. We saw strategies have to be put into place to protect physical health, so make sure PPE was available, make sure healthcare workers were prioritised for vaccines, make sure they were prioritised for testing. And we saw practical support measures, so healthcare workers were given accommodation if they had to shield from, if their family had to shield. They were given childcare if schools were closed. They were given transport to be able to still get to work if transport was otherwise closed down. So just across all areas and across the whole region, a huge range of actions were taken. And to implement them, it involved pretty much everyone. It involved policymakers, it involved regulators, it involved education specialists, it involved healthcare workers themselves and facility managers. So everybody had to come together and work together to put these reforms in place. And they had to do so rapidly. And we saw governance changes in all areas. So we had to have national policies put in place to authorise massive new funding for these reforms. We had to authorise health workers to take on new tasks. New legislation, we needed indemnification for healthcare workers to be able to take on new tasks. Legislation had to be suspended in some countries because healthcare workers weren't able to access mental health support by themselves. Regulation, new training and development of new competencies, development of scope of practice for new workers were put into place. And employers and managers themselves had to take on training, supervision. They had to make sure the work environment was safe. They had to start monitoring staff absences, which in many countries hadn't been done before, and it was done in real time. So a lot happened. It was challenging, but there's so much that happened that was new or new for a specific country that we can learn from. So we saw improved salaries and other support measures were put into place inside and outside the work environment. These have now, we knew this before, we knew they were key to retention, but finally people started to take some action and put them into place. The importance of protecting and supporting mental health and well-being now has shot up the list of priorities, and people recognise far more needs to be done. And of course that, as Josep said before, this relates to improved salaries and work conditions. Health workers themselves have been given leadership roles that perhaps they didn't have before. We've seen a really good innovation, actually, in most countries, is the uptake and use of digital health tools, so electronic health records, remote consultations, monitoring systems for monitoring staff. This is going to be hugely important going forward, and links to one of the 10 actions for improving data that we have. We've got new competencies were developed, training programs were put into place, making use of online delivery. Change on scope of practice were agreed really rapidly, even though they'd been resisted before by professional bodies and other people for perhaps 10, 15 years. New funding was magically found. So when we want to act, we can find the funding to do so. And then digital monitoring systems were put into place to monitor numbers, to monitor absenteeism. And going forward, it's going to be really important to learn from what works to help strengthen the workforce.
Thank you very much, Gemma, for really showing us how innovative, how creative, how resilient the workforce was. But what worries me is that now that kind of the pandemic perhaps is receding a bit, people have already moved on to the next big thing, and that we forget about the workforce. And this is why we are here today, because this is not going to go away, and we are not going to allow it to go away. And people who are definitely not going to allow it to go away are our young healthcare professionals. And we are delighted that we are joined by Atanas Monvilla, who is the Vice President of the European Junior Doctors. And of course, they are caught in between a workforce that is rapidly aging. Thomas said, you know, in 10 years' time, in some countries, 40% of your colleagues are going to have retired. And on the other hand, in some countries, what we are finding is difficulties to attract, recruit, and retain immediately upon graduation also the new doctors and nurses. So Atanas, thank you very much for joining us. And we know that you are actively working as an organization also to shed light on this issue and also to perhaps provide, from your perspective, suggestions about what needs to be done. I'd like to invite you to reflect on what you have heard from Thomas and Gemma, and to tell us a little bit about the work that your organization is doing and your asks to the audience here. You have the Observatory, you have a European Commission, you have a number of Brussels-based NGOs who, like you, are very good at raising awareness and advocacy. Over to you.
Okay, so hello everyone, and thanks WHO, European Observatory of Health, and everyone who are making this session to happen. We are really pleased that this topic is finally getting higher and higher on the agenda, and I think we can, fully sign with any 10 actions that's provided here, because on work we do in our organization, we actually checked our archives, and we realized that from 80s, we started discussing about the medical workforce, the problems on medical workforce. We organized conferences on the topics, and now, thanks maybe again to the COVID, we finally again can put on this light. And I think we kind of even agree with this. We also kind of did some research with our associations. We represent 23 countries in our organization. It's over 300,000 junior doctors across Europe. And we kind of investigated, and maybe I would like just to introduce a bit what kind of problems we see, just even like we've been asked to complain a bit, but I just need to kind of to give a bit different perspective from the battlefield, as we can call it. So I think, and as we all agree here, we have a great problem with shortage of doctors. However, as an organization that represents junior ones, there's a bit different perspective, because usually the nurses and junior doctors are the ones mostly affected of the increasing work, because you need to do all these daily administrative tasks. You need to kind of basically make and run the hospital, all these daily tasks that need to be run. And it's natural that when you get more and more senior, you deal with more like decision making. But when you have like such a great shortage of doctors and medical workforce in the hospital, so there's a great pressure increasing on medical workforce, and which results in poorer care, because you don't have time. You need to, you have more stress on the workforce, so you're not able to deliver adequate care, and also your training. You spend less time on training. And then, of course, there is other great problem that we have a bottlenecks for doctors to enter the training spots. You have, some countries don't have enough students, but some countries overproduce students, and then we don't have enough space to actually get the training spots and to prepare residents. There's also called medical deserts. We kind of appreciate that, and we understand that. And I think it's also important to understand that it's not because people don't want to go to work in the rural hospitals, maybe they don't have equipment, but it's more like the broader cultural aspect about it, because generally people don't want to live in rural areas. So we need to address it at the broader perspective, I guess. And the brain drain, we kind of really appreciate that and we see it for a long time, that the brain drain is so we have countries that kind of provides physicians to other countries, and hopefully now we have this result, because we've been discussing for years that we don't have enough data and proper health workforce planning tools. Some countries that they just don't know how they plan their workforce. They just, how many numbers we had last year? Let's prepare the same number of doctors. So we also believe that this needs to be addressed quite adequately. And I think one of the other major problems that we haven't addressed it yet is just silent quitting. People just leave profession. And now if you talk with like UK example, 2 of 5 doctors just want to leave the profession entirely, not even because they're tiring. They're kind of young, energetic professionals, highly skilled. Because we tend to believe that kind of, and the culture, I think, plays a major role here, because we tend to believe, and we knew that, you did the training 10 years, there are not that many spots for you to work in, there are not many professions that can, provide you the same compensation, some status in society. But now people leave the profession, they work in industry, and they're really seeking for better culture, I would say. And it's also very important to appreciate the fact that we get more and more women in the field. And what you would see now, we still have the leadership and the representation of, like in medical association and other professionals, they are all, not all, but most of the time they run by men. And I think we need to have more representation of women here. So we as juniors, we're actively pushing for this, and we hope that we can address the cultural problem. I know that there is no quick fix on the culture, but I think anyone who's coming from healthcare, especially from practicing healthcare, the problems with the hierarchical culture, the way doctors are treated. We have friends, we have colleagues who work in other industries, tech, and we know how other industries kind of treating their patients. So I think it's important to kind of learn from other industries as well. And if you focus now more a bit, because I think we in the rush just to how to address these problems. Some first thing I think actually is done. We have more of cooperation, we have more discussion, we have more inclusion of different professions. So I'm pretty sure that we will be able to continue our work. We'll be able to represent medical professionals, not only doctors, but nurses, other professionals in the future works that actually plan with WHO. We also invite maybe, and we will be able to kind of initiate our perspective and our work with trying to build a pan-European goal, and what medical professionals would like to see as their ideal working conditions, ideal workforce. So we would definitely...
That's what we're going to be discussing.
Yeah, but this is going to be discussed in future. And the last, exactly. I think, just
we need to have the views of the audience.
Yeah,
as well.
So one minute just to finalize. I think, and I will just use my kind of junior role to be more ambitious. I think we kind of...
Your moonshot, Atanas, what is your moonshot?
So
exactly.
Yeah, so moonshot is to understand that this problem is not a quick fix. It's a way broader problem, which is related with how we structure healthcare. And I think if we will kind of try to address this, increasing funding and preparing the same amount of doctors that we need for the current healthcare system, we understand it's not going to happen.
It's not going to work.
Yeah, so because we need to have like future.
So
future views.
thank you very much, really,
Indeed.
for some really important points. Just two that I would like to mention. And in the meantime, I would like also to bring up your Slido voting results. But just to mention 2 points that Anna picked out on the data. And I would like to say that when you look closely at the report, you will find lack of data and also the role of women and the fact that the professions are still sometimes very much represented by men. So, Josep, what do we have? Thomas, what do you think? Action 5, create working conditions that promote a healthy work-life balance. I think this is really what Atanas was just telling us. They compare their life to their colleagues working in tech, and their lives don't even start to compare. I don't know what we're going to do about that, Josep, but clearly we have to find solutions, and I think the younger generation will help us to find them. The other one, develop strategies that attract and retain health workers in rural and remote areas. I see our regional director has just arrived and is taking notes already. He will be familiar with that one because every single minister comes and tells him that this is their big problem. And the third one, we spoke about it yesterday during an amazing session, mental health and well-being. So, I mean, I think, Thomas, we can roll up our sleeves and start to act, no?
Yeah, fully agree, Natasha. And I think it aligns pretty much what we were getting in the report, these 3 main priority areas. And I don't want to take more time, but I think we are really looking forward to keep working on this. Our next step is going to be, we're going to have a regional meeting in Bucharest in March, and the main idea is bringing all the relevant stakeholders from governments, associations, professionals, academia, and try to discuss and agree on how we can take this forward with these priorities. Thank you.
Perfect. Thank you very, very much indeed. The first question to you, did you vote with your emotions, with your heart? Did you vote with the evidence what makes a difference? Or did you vote politically? You know, I thought the young generation would be the dreamers that they vote with their heart. Yesterday I was with the younger Steiners, I see some here, and I was totally surprised. The only dreamer was me. They were saying, no, Joseph, they can't be the European Health Union. No, this is not practical. No, this is not possible. So I don't know anymore. But I think it's very important when we look at that. How did you vote for that? How much of that feasible? And I'm going to start, no, put it back, please. My memory is very short. Could you put it back? Because we're using that. Perfect. Antanas doesn't want to go and work in a rural area, right? You're telling us, and you don't want to go there, and then you're telling us that this is one of the main areas. But they don't want to go there. What do we do about this? So can I have some reflections from you? First, as you made the effort to come to the Alps, sorry those online, thank you for being online as well. Oh, I said something politically incorrect, right?
I've already been receiving WhatsApps from people out there telling us what a great session. This is very encouraging. So thank you for being online also.
Let's do that. Thank you. You know, she's correcting my politically incorrect mistakes. You know, it's always like that with Natasha. Bad cop, good cop. Anyway, let's not talk about ourselves, but what you, those of you in the room get priority, but short. Pum, pum, pum. No complaining. What do we do about that? You see what you voted. I'm not sure I agree, actually, but what I agree or not is not the problem. I like to see more skill mix in here, right? No, they're down. I'm not interested. I'm just a politician. I want the big voting. This is the ones that are going to elect me. So I'm not running for anything. So where is the skill mix here, actually? I'm sure Martin will be talking about that. He ran a very good panel. Later on, we'll hear from Matthias, who did lots of research in this area. So tell me, how do we implement all that? Practical actions. Where's the microphone? I said, I will abort you if you don't say anything, so mini money poo, you know? Hey, thank you very much. You get a drink from me later on.
Thank you so much. My name is Elke Grote. I'm a Belgian pharmacist. I work for the moment for Novartis, pharma company.
Why pharmacists are not really working in the health profession? Why they only sell drugs and they're not there to really give advice, chronic prescription and so on? That would be a good skill mix development, right?
It's one of my proposed actions. So I have 2 proposals.
Only 2 proposals, very short.
2 proposals. The first proposal is related to future health crises. I'm also a representative in HERA, in the setup of HERA, where we discuss plug-in capacity for manufacturing. And one of the proposals I made there is, Gemma, to your presentation, many of the healthcare professionals working in other sectors, education, industry, and so on, also stepped in. I have my own experience during COVID. So maybe what we need to build is a plug-in capacity also for healthcare workers that work as me is in industry or in education. That
You will
can
prepare
step
to leave
in.
the industry and go back to the practice?
We can discuss about it.
Good. Next one.
And then my other proposal is if you look at many tasks, actions that are needed in healthcare, you need high qualifications. And with the digital transformation in healthcare, I think we should also look at this qualification. On one hand, we have a lot of unemployment, but on the other hand, we have, as you mentioned also, doctors, pharmacists, performing very administrative tasks. And I do believe, as an optimist, that digital tools can help us there and we can bring in a whole different workforce.
It's not as
into
easy as that,
healthcare.
but we'll hear from the European Commission has a major training program on digital skills and green skills for the health profession. Thank you very much indeed. And WHO indeed is led a major initiative on this area. I got a point here. Introduce yourself and very quickly, shorter.
Well, I wanted to reflect on... I'm at UCL and I have a lot of young, doctor friends essentially, and I'm seeing this trend of this desire to move rather into the tech industry. I had a friend who's in her 4th year in her medical studies, and she was considering, there was this existential question of, shouldn't I start a computer science degree instead now? Isn't that going to allow for a much more decent job? And so I was wondering, is there a social obligation for medical students to become doctors or not? And if not, because there is still her desire to do a lot of medical research, but not so much to do practice. And as such, is there an element of dynamism there? A possibility for retraining?
So, colleagues, pay attention. We'll go back to you on these questions, okay?
Because
next one, quickly.
Because
sorry to put pressure. It's
no
just I
problem.
want to hear more points.
Last sentence, maybe 18 is too young to decide on one's future career trajectory for the rest of one's life.
Very, very relevant indeed. Very relevant indeed. I got some young kids that are facing the same problems. I had an issue
Not
here.
young, I'm sorry.
No, I'm talking about my young kids.
Okay, sorry. I would say very simply, make care as a future attractive and sexy image again, because the majority is female, and we do know that jobs that we make as women are negative and minor and not really attractive and not really seen. And I think that we could put on this and make it to be a sexy, future, attractive and innovative and very, very important job.
Perfect.
I think
and
that
Tana, will you
that's
tell us
needed.
how you do that? How you make it more sexy, more interesting? The other day I saw
Good for
an ad
us to
about
know how to
recruiting
do it.
priests, making priests a very sexy job. Seriously, help the others. We could do much more with the profession, right? I had a point here. Oh, Vesna.
Thank you very much.
I'll ask you to be short as well, even if you are my boss.
Yeah, okay, you already spent some time telling me this. So now we have here something that is what needs to be done. We know why, because
How?
people are leaving. Now, how this is going to be done?
Making it more attractive, more sexy. Helping the young people.
How making more attractive and so on. You're all the time speaking of what, but to find how,
Campaigns.
we need to be very innovative. We have to start thinking of how we will create working conditions. We have
I'm
to
asking
use
you that.
the digital.
How?
The digital opportunities. We need to involve other professionals to release doctors from the work that they are not capable of doing it. For example, there is a demand, we were speaking of needs of population, to navigate people through the system. We are speaking of health literacy, etc. Who is going to deal with this? And this makes doctors very frustrated because they cannot cope with all the roles they have to execute in their practice. So let's think about how we are going to create, develop, protect, and I don't know what. I think
Perfect.
There we need some people that will start thinking of this and start innovating, because this will be innovations. Thank you.
Gemma, will you react on the innovations? Not now, later. Will you react on innovations on the skill mix we saw and so on?
And Giuseppe,
Please,
we
take
also
over.
need to ensure, given it's a hybrid event, otherwise our organizers will tell us that we forgot it's a hybrid event, to take at least a couple of questions that have come in online. Chris, can you pick a couple of the questions that have come in?
Thank you, Natasha. Yeah, it's been very busy on here. there's a lot of comments mirroring the audience on investment in wages and conditions, looking at retention and looking at the policies of protecting health workers. Two key things coming out that are different, though. How do we make the financial case for investing when budgets are limited? What can researchers, implementers and policymakers do to make the economic argument for investment? And also one about the demographic factor and the imbalance between retirement and workers leaving the system. How complicated is it? Is it time to reconsider how we slow down brain drain from countries to other countries?
Wow, that's some food for thought. Josep, I think demography, migration, these are the easy issues, no?
I think the migration and we'll be dealing with in the next session, as is very much something within the EU, but also we'll be talking about neighbor countries and the migration towards American countries. So we can perhaps park that one fundamental. And the other one, why don't we actually ask is there anybody else in the session? Okay. Martin, you couldn't fail me.
Joseph hands it over very reluctantly.
Indeed.
Okay, we're talking about moonshots, but I'd put it to you that this is not rocket science. And maybe we just need to look at those occupations that don't have the same problem that can attract and retain staff and learn from them. And maybe we say that if you pay people well and if you treat people properly, they will come and they will stay. And the problem is we don't treat people well, we don't pay them properly, and that's the reality. And I'm just fed up with health ministers saying, we have a problem with health worker staffing, because it's a problem that they can do something about. We don't need to make the case for the economic case for investing in health. We have it. We made it in a report in 2005. We know it's all out there. It was in the, in fact, back in 2000, other people did. So it's there.
Martin, are the population prepared to put more money into the health
system?
Yeah, they
are. If you poll,
are they?
Yes,
do you agree?
They are. And if you look at the reaction of to the British government's budget for cutting taxes, you will see that people are willing to pay more. So, we just ask them. But
do we agree in the room? Yeah.
If you have politicians that are being influenced by lobbyists who are arguing against this, then you've got to say, who are they listening to? Are they listening to the lobbyists in, Tufton Street in London and elsewhere? Or are they listening to the people who vote them in? And the answer is, generally, they're not listening to the people who vote for them.
Thank you very much. I will ask our panelists to begin to react to some of that. I'll leave you last, Thomas, and my colleague Natasha to wrap up and see what we heard today. Can I ask with Gemma? Gemma, very briefly, we really learned a lot about the skill mix during the crisis. How many crises do we need to adopt this new skill mix? Do we need another crisis? Do we need things worse? Because what worries me is we're going backwards, even with telemedicine. We're talking about digital. I've seen some countries going backwards. So how many crises we need to learn the lesson?
Mm-hmm. Yeah, no, I think this time I was going to say exactly what Martin just said, that we know and we have known for 10, 15 years what we have to do to strengthen the health workforce, to get people to stay in the workforce, to make sure young people are happy. And policymakers just don't do it. We have the evidence base, and it's just been building and building and building, and it sort of gets ignored. And that's on working conditions, but it's on skill mix. I mean, the Observatory, we've just published a book on skill mix. It's we now know the strategies that work in different contexts, different countries. We know that it can save money, it can make everything more efficient. We have the evidence there, but countries just don't do it. Sometimes professional bodies don't want changes to be made for various reasons, often valid reasons. But we know this, and we know what we've got to do to implement them. Use digital technologies, it's all there. Some countries are doing really, really well, other countries doing very badly. And often they fall back on, it's a technological challenge, but it's often not. It's often putting the regulatory environment in place and finding the money to get everything implemented. And then, of course, training the health workers, which I think is actually quite neglected with digital technologies. But at the same time, the European Commission are now we're working on a big project called Be Well, which is mapping the digital skills and the new professions that we're going to need to work with digital technologies going forward. So we have a large evidence base. It's being built on all the time, but people need to take action. Just going back, Martin really summed everything up beautifully, that we know what has to be done, but people just don't do it.
Yeah, and actually the work, Dimi, we did together with Nick, who's in the room as well, and colleagues, and you, Gemma, when we look at digital, we look very much at enabling, as you said, the regulation, the governance, the training, that sometimes I worry that there's enough resources, enough support. We look at the technology, but not at the rest, although the Be Well is a good example. Very briefly, you are in the medical profession. Why? What made it sexy and attractive to you? Is it money? Is it the white coat? I used to like to wear a white coat when I was a doctor.
I'm a radiologist. I don't wear the white coat. I don't. But the thing is, it's not the money as well. It's not the money anymore. And maybe just to reflect, we need to break the myth that doctors are a different breed. They're not like, if they choose medicine, it doesn't mean that they will. No, they gave the Hippocratic Oath. Oh, they will go to the village and serve in the village because we need them. No, it's not. The generations are changing. You know, we're not like Good Samaritan.
No humanists among the doctors anymore?
So I think there are humanists, and the reason why they choose the profession, they want to help people. But when you find large numbers of doctors losing meaning in their job, it means that we don't deliver care in the way that's meaningful. So I think this is the problem with how we see it. We see that, and actually we understand it's not like we will get more workforce, we will get more people, more nurses. Actually, it's a new reality. We will not get more doctors, we will not get more healthcare professionals.
So what do we do?
We need to transform the way we deliver care. We need to kind of
flexibility.
More home.
Action 10. It's Action 10. It
It's
didn't
Action
make
10
it to
is
the
the
top
most
ones.
important.
Yeah.
And if we can use all the digital tools in the world, but like if we do unnecessary and meaningful tasks, consultations that are not necessary, and if we not focus on prevention and moving outside from specialization more to kind of home care, that's it. That's the only way to go. And
I think
that's why you make it sexy.
That's a touch to reality we needed to hear. And people, the young people are voting, and Vesna is voting as well to you. Briefly, wrapping up, because we're running late, my fault, and then Natasha will do the wrap up. And gain all the time I missed and lost.
I was going to bring the issue on working conditions, but bringing the angle of flexibility. I think with the young generations coming, I think it's important also how we arrange work, because the way we have been doing for the past, in terms, just an example of 24-hour night shifts that's coming from the US, beginning of 20th century, that's not attractive enough, and it's not serving the purpose of young generations of conciliating personal life with work-life balance. So we need to be innovative in also bringing these new working arrangements and linking with innovation. I think we normally think innovation in health systems from a digital health perspective, but innovation has to come through how we innovate in this working arrangement, flexible working arrangement, and new innovative ideas on health workforce, because that's the way, is the major source, is the major spending and investment in the health system, and innovation has to come through that way. And the last point, if we want to make this happen, we need to place health at the highest political agenda. So I think that's the major challenge. This is political, is how between all of us and with civil society, we really manage to position this at that high level so we can have the investment we need to make all these changes happen.
Thank you very much. So this brings the first part of this session to an end. I ask you to join me in giving a round of applause to our amazing presenters, and also to all those online. Chris tells me there's a lot coming in. What did I hear? I heard that this is ultimately a political issue. Yes, we've put it on the agenda. I heard that we need to be very realistic about the way in which we make working in healthcare more attractive from a work-life balance point of view. Because people are attracted because there are a lot of good people in the world. I believe that there are a lot of good people in the world. I believe there are a lot of good young people in the world who want to make a difference. But let's provide them with the working conditions where they feel that they can, yes, make a difference, but also live their own life, have their own families, and have this important balance. And I think when we talk about making work attractive, we want people to feel that they can work to help others. This is why they signed up, but they can also lead their own lives. And I think one of the things that has come out is what I always tell Thomas and Chris, put to the bottom of the list, because nobody understands it. The famous work governance. But in this session, we have unpacked what it means. What we now need to do is to find the way in which we can activate those levers, because it's not enough to go to the ministries of health, because this is a complex area. we've got ministries of education, we've got the unions we need to be talking to. It's in many countries very much within the realm of the professions for historical reasons. So I think we now need to go into that middle level where we activate the levers. Having said that, the role of organizations like WHO and the European Commission remains very important, and so we now come to the next session, and I invite the Regional Director, Dr. Hans Kluge, Isabel de la Mata, the Principal Advisor from the European Commission, and also we have a Member State representative from a country outside the European Union, and therefore I would like also to welcome Svetlana Nicolescu to take the floor. And Matthias, I forgot Matthias. How did I do that? Matthias, please. And hand over to Joseph to moderate the first part of this panel. Yes.
Can I invite Hans to set us off on this session?
Thank you, Giuseppe, and everyone. I will try also to improvise a little bit because a lot of my notes seem a bit outdated after such a rich discussion, really, right? So, Giuseppe, you're very good in this, right? I saw to stop and halt and change.
I wouldn't dare do that with you.
But I really want to flag again that, because we're quite proud of this, that we launched for the first time this WHO European report on the state of health and care workforce in the region, and it has data from all 53 countries, because you want to leave no one behind. And it gets a lot of traction, time to act. So what Tomas mentioned, the aging issue in the region, is indeed something for urgent action. I believe it was 40% from the medical doctors in the countries which reported who are close to retirement age. And we had also discussion bilateral with President Clemens Auer, who was telling also in Austria, I mean, this is basically close to collapse. So this is very, very critical. Maybe I will talk a little bit less, Joseph, and listen more, because I saw some principle also differences in opinions in the discussions, right? Is it, I heard we need to respect the workforce and treat them very well and pay them. But then I was in Iceland 2 weeks ago talking to a good friend, Svein Magnusson, who used to be the Director General of the health system. He was, before going to the Ministry of Health, a doctor in one of the rural areas in Iceland. You know, beautiful country, a lot of rural areas. And he was telling Hans, if you discuss workforce, take into account the environment and the living conditions. He was telling, I was the only doctor. Everyone knew me. Whether I went to the swimming pool or to the shop, you know, together with the mayor and the notary, and I was very proud, he told. But he told, no, for younger people it's different, because they want to live a little bit more in anonymity. Not that they are being recognized everywhere and they don't have a social life. I remember my father was working 24/7. Actually, he's 88 and he still would like to work 24/7, but he only works 10/7 now. But, you know, and for me, this was in the beginning of my career as well. And I remember that one of my girlfriends was telling, but like this, I will not marry you. Because to be the whole time then at the phone at home and never. So this is a whole evolution and also of feminization of the workforce. And I don't think we can say that one was better than the other. It's just that we have to adopt, give good working conditions, definitely. I think a big one, which also frustrated me as a GP, so much administrative work. And I hear this from my colleagues who are still clinicians. I mean, there's just too much of administrative work on the clinicians. And what younger people tell me is important is research opportunities, to have really this one. And then, of course, you know what I'm going to tell. I'm a great advocate for nursing and midwives. I think we still far underutilize our wonderful nursing and midwifery workforce. I'm very grateful to Israel. The day after the Regional Committee, we reinstalled our annual tradition of calling the chief government nursing officers together, which in itself is a great signal to the Minister of Health and the chief medical doctors, right? And then finally, really very sincere appreciation to Romania, our good friend, Professor Alexandru Rafila, the Minister of Health. In fact, in Romania, you have 700 towns and villages currently without a doctor. And Professor Rafila is going to host a regional meeting on this issue in March of next year, speaking about raising the political commitment. But now, Josep, I will listen in. I tremendously enjoy what I heard, and please rest assured that we are very well aware of the acuteness of the situation.
Thank you. Thanks very much, Hans. Perfect link from the last session. And please stick around if you can to have some reflections perhaps at the end. Well, I'll ask you to vote now to see how many skeptics in the room I got. This session is about the European Health Union. This conference is about the whole of Europe, not only European Health Union, but it's about moonshots. It's about what can we do from the European Health Union in this case, and then we'll hear for neighbor countries. So the first question, please, to see how many of you, perfect. And I'd like to have the voting live. So a true European Health Union, this is the title of this conference, by the way, should increase its competences in health workforce development. We'll not ask you this question, Isabel. You are a civil servant, so you're here to be politically correct. But yes, we are asking whether it should increase its competences in health workforce development. Please choose one of the following responses. Yes. 100%, one person has voted. Yes, a strong European Health Union action is key to address current health workforce crisis. The more pragmatic said, yes, of course. Ideally, but member states will oppose to increase EHU competences. I cannot believe it. No one is voting or what? Okay, oh, that's getting better. No, member state subsidiarity in health workforce decision must prevail. These are my skeptics. I'll ask you who you are. Oh. No, member state subsidiarity. Oh no, what's happening now? Sorry, I got lost. So, no, the EU should first implement, Isabel, you are not yet implementing well enough its current competencies. Why are you asking? You're not asking, I'm asking to have more competencies. Okay? So let's see. Go on with it. Oh, I like it. Okay, yes. Too many pragmatics, though, that worries me. Where are my idealists? Come on, guys, keep going. We cannot waste time with this.
Entire value-free questionnaire, then, is it?
Yes, entirely. And me, as you can see, I'm very neutral, as you can see. I'm totally neutral on the subject. My values are not available, right? And but I can change my values if you want. Okay, I think we got a good sense already. Really, it's a lot of yes, but with some worries. And we'll be talking about these worries as well. We are in a practical session today. Next one, which is even more complicated, and in that one you even have to think. Okay, next one, please. Oh, people have voted on the second one already. Okay, excellent. So here what we're asking you is, what are the priority actions? A bit the same we heard earlier, so it really chimes beautifully well with the prior session and the priorities that WHO put forward. And then we are saying in these competencies, because you all agreed that they needed more competencies, we are looking at what are the kinds of competencies. Isabel, I'll be asking you, get ready, about how you is supporting health workforce skills development and lifelong learning programs, something that Matthias has been championing for a long time, is all about lifelong training. Then the next one there I can see almost in a draw is led collaboration on health workforce training. Again, we'll talk a lot about training. But of course, the small countries want to be trained elsewhere. Do the big countries want to train the others? And who's going to pay the bill? A question for you as well, Isabel. And Matthias, Svetlana, you come later and talk about the Moldovan and neighborhood perspective, but I'll start with them too, and Natasha will help me in that second part of the session. Shared curriculum development and standardization, I think is something clearly, if there is mobility, we need to have much more on CV, on developing these common CVs, on standardization. One is very controversial. I need to ask you, Isabel and Matthias. Matthias will be able to say more daring things. Should the EU have policies on shortages and retention policies? And no one is voting for my favorite one. EU stronger monitoring and regulation of mobility. I know mobility is a right and has lots of positive things, but has negative things as well, brain drain. No one wants the EU, look, only 9% to do that. Isabel, why is that? But last Matthias, even if the last one is my favorite one, so last Matthias to say, okay, I think I said enough already. You got a very clear sense. I hope by that you've been reflecting, and later on you'll be, when Natasha's coordinating your reactions, be able to come on that. Okay, let me start on the... Oh, actually, yeah, thank you. Health workforce skills. What are you doing? But as no one is seeing us, Isabel, in a dream situation, what do you think that you should be doing? And if you don't want to say that, I'll ask Matthias. Get ready, Matthias.
We are doing a lot of things. You already know that we are doing a lot of things. We are doing this Pact for the Skills. We are doing the training activity under the EU for Health program. We did, I mean, in fact, the training activity comes because during the COVID pandemic, with the emergency support instrument, we were funding this activity to train 17,000 health professionals, doctors and nurses, for ICU skills, intensive care skills, and that was quite successful. I mean, 17,000 people trained, people that they were not specialists on that, so it was to support the intensive care unit that were under stress at that moment and that we needed additional professionals. The problem with this kind of activities is that we can train, we can work on having different skills or more skills or working on a skill mix and etc. But we don't know what happened with those people. I mean, we don't know if the 17,000 that we trained were really engaged by the member state, by the health system where they were working or that they were aiming to work or not. We know just the beginning, what we did. What happened with them, we don't know. So this is also an issue. It's not really our responsibility. I mean, we are doing that because we have agreed with the member states and under the EU for Health program, and because we think that working on skills is really important. But you know that under the EU legislation, the competence, the obligation for training the healthcare professionals and other professionals comes under the member state. So we are not discussing all the time, as we did before, this is for me, this is for you, Article 168. I think that during the pandemic and now after, if we are after, we move from that discussion, and what we are discussing is not the competencies, but what can we really do in the real life. I mean, with the competence that we have and with the agreement of everybody. So we discuss with the member state, we discuss with other organizations, and we go ahead to the best that we do, that we can. You were mentioning the regulation, your favorite one. I don't know if you want to enter now or later.
Regulation of mobility.
Yeah.
Yeah, let me go back to that in a second. But people are telling you, that they want more health workforce skills development and more training. I mean, the Maltese presidency put forward actually an Erasmus for training of specialists. Small countries and bigger countries could benefit actually of training schemes that people return back home. Mm-hmm. What are your thoughts on that? Do you think there is a space to increase those competencies? Of course, it's a matter of member states, not a matter of you.
It's not a question of competencies. We can do that. I mean, we can train. We have one instrument that is the EU for Health, and we have the other.
No, I'm talking coordinating member states having an Erasmus by which doctors can move and nurses and be trained elsewhere and go back to their own countries.
But this should be voluntary. Or this, the only way that we can do that is that this will be voluntary. So if we agree with the member state and we do that, but that cannot be compulsory because we don't have the legal basis to do that compulsory.
We've seen a number of areas, Isabel, where member states like to play with each other, some of the smaller ones, and do these kinds of things. If a group of member states comes to you now and says, we want to work together, would the Commission support them in training each other?
Wonderful. So we begin to discuss that, and we have the instrument that is, I insist, the EU for Health. The beauty of the EU for Health is that first, the budget was increased by 12 times with the new program, and that we discuss all the activities we discuss with the steering committee that is composed by the member state, and also that we have a consultation where all the stakeholders can say what they think that are the priorities. So we have the instrument, we have the possibility, but there are many other competing activities where member states want to work.
Good.
What we cannot do is, I mean, if member states come and say, we would like to work with you on a compulsory program with legal base to do that, say, we don't have the legal basis. We can work on that with you, but maybe we will need a legal basis before.
Perfect.
But we can do that. I insist.
You have the competencies to do that if member states ask you to do that. It's been like the joint procurement other areas where you're capable to do it. I'll bring you back on mobility and later on the reactions from our colleagues here. Matthias, skill mix. What can you tell us about that? How the European Union could move forward? Are you agree with Isabel that is enough with the competencies we have at the moment to do the kinds of things we need should be happening?
No, I think we need to go further. And if I think about
use the microphone.
Oh, yeah. I think we need to go further. And if I think about the topic in terms of a moonshot, I would like to see the potential of health workers in primary and chronic care unleashed, and we can unleash it by skill mix. And actually, it's again an issue where the evidence is here. And Gemma was just mentioning we've done this unbelievable, huge overview of reviews with all the methodologies you need. And we have clearly seen that there are skill mixes that have demonstrated to be beneficial for patients and health systems. I just give you very quickly a couple of ideas. Dedicated roles for nurses in health promotion, advanced practice roles for nurses, pharmacists, physiotherapists, nurses in new settings like hospital at home. We have seen coordination roles as really vital and making a difference, and of course, teamwork. And one of the messages I want to bring across here, this, I mean, I'm surrounded by doctors. Hans, you're a doctor, you're probably a doctor, you're a doctor, you know. Ooh, it's scary because doctor's world, we are living in our health system, but the future is a nurse's world if we want to have a future. These skill mixes are all focusing actually on nurses, on teams, on changing the way doctors interact with the rest of the health workforce, and we need to get used to it. And I think this is one thing. That would be one of the moonshots for me to get this acknowledged.
What the European Health Union should do on this?
Oh, wow, yes. A lot, actually. Number 4 is, of course, training, supporting training. And we not need only curricula. Curricular development will be important, and we need to have some common standards in it. But what we need is continuous professional development, because we need to get the skills on short notice into the health workforce, and we don't need to get the skills to each and every member of it, because some will need it, some won't need it. So I think that we really here need some sort of European system for the future. Still, I mean,
is there a system for the big and the small?
For the big and the small
countries. The big countries don't need that much. The small countries need more.
You wouldn't believe. I don't know if somebody from France is. France has one of the most advanced systems of continuous professional development. It's centralized, actually, and you hear the people in the sickness fund say that it's useless. You know, and I think we have problems with our.
French in the room?
We have problems with our continuous professional development models, and in very many countries, it's actually done by the doctors themselves and not necessarily directed towards health systems goals.
Very briefly, because we need to continue, my co-moderator is using the technique of in my back to push me.
Very briefly.
So one response.
Yeah,
but then I'd like to talk about mobility, if you have
very briefly, a touch of reality. When we were discussing at the end of 2018 the Council recommendation on vaccination, we try to introduce, I mean the Commission, we try to introduce that all the health professionals could collaborate and could put the vaccines. We need to withdraw that and put in a different way because the member state refused, because in every member state who give the vaccines is different. So they didn't want that we introduce specifically the profession that we had introduced at that moment. In our draft. So at the end, the member states want to keep the competencies on the skill mix and to decide how the system is.
And even in the calendar of vaccines, which is something not of the EU, but should be WHO, establishing across the whole region. We move to neighbor countries.
Yes, and of course, I mean, I'm a firm believer that the EU can exert a lot of influence in this area, directly and indirectly. But one of the greatest opportunities for the EU to actually push countries to improve their workforce policies is around the time of European accession and membership. And we have a number of countries in the wider WHO region who at the moment are on some part in that trajectory. And one of the countries, a small country, again, I have a bias. You see, it's not only Josep who has biases. From Moldova, Svetlana will share with us a little bit some of the challenges that they are facing in Moldova, a non-EU, small country perspective. But I've also asked her to be a little bit bold, a little bit tosta in Maltese or Italian, we would say. She's got the regional director sitting on one side. She's got Isabel Della Matta sitting on another. She has Matthias, who is ready to assemble all the evidence for her, as they usually do very well. What would be her asks? So, Svetlana, thank you for joining us, and over to you.
Thank you very much, Natasha. And I have to say that I'm truly delighted to be part of this debate and to have this opportunity to present and to provide here the perception and the position from the country level perspective. So I would invite you as audience to reflect and to be conscious that the whole dynamics of the health worker mobility within the EU environment, it actually shapes the different country profiles for healthcare workers in our region. And it actually goes much beyond the EU borders. And let's have an example. Let's have a look at Moldova as one of example countries. Actually, the WHO report very nicely reveals all these differences for the different country profiles. When we look at the Moldova, and I will invite you to look only on two figures, on two numbers. The report contains much more very nice data. But if we look at the Moldova for the healthcare workforce capacity production, the value, this indicator for Moldova is well above the regional average. It means that Moldova indeed produces healthcare workforce. Now, when we have a look at another indicator, the coverage or the healthcare workers' density, here we come across a totally different picture. And here the numbers, Moldova stands among the countries with one of the lowest healthcare workforce density. What does it mean to us, and what does it mean for the region as a whole? It means that today, similar to other countries in the region, Moldova is a source country for healthcare workers for the region. Indeed, today we face one of the major challenges that the graduates, health care graduates, they actually do not join the domestic healthcare workforce. So they are leaving the national health system. We're also facing a major outflow of our health workers already involved and engaged in the system. Well, it actually brings a lot of other broader challenges, because this outflow of healthcare workers, it also translates in a greater impact. It relates to difficulties in planning for healthcare workforce, because we do not have reliable projections how it will change in the years. It also translates in losing our investment in producing health workforce, because in Moldova, similar to other countries, medical education is for free. So we use the taxpayer money to produce healthcare workforce, which afterwards we are losing. And without going into the more details for this complexity, I will move to my second point, which relates to the importance of EU policies in this area, and the importance to consider and to engage the neighboring countries, the non-EU member countries, at the time when these policies are shaped, are formulated, in order to consider at least one predictable factors that could negatively impact the healthcare systems of our countries, because all of our countries, we have to support the right for the mobility for our healthcare workers, but we cannot ignore the other impact that it will produce and can produce, and the one we already face for our health care system. So here comes the greatest challenge, to find this right balance between promoting and supporting the right for the mobility, and at the same time to find a right type of solutions of mitigating some of the negative impacts that it inevitably has on our health for workforce capacities and the systems overall. So what would be our ask to include and to make sure that countries similar to Moldova and Moldova as well are part of these dialogues, are part of these discussions. Whenever the EU regional policies are shaped, we need to consider how it will reflect and how it will impact not only EU member states, but the other countries from the region as well. And my last point in this panel would also be to look at the broader opportunities and at the national agendas and context overall. And regional director already mentioned today the importance of creating the favorable environment for healthcare workers and good conditions, not only working conditions, but also living conditions. And here, more opportunities come for Moldova as for other countries as well. So Moldova on June 23 received EU candidate status, well, under the commitments of structural reforms, but this clear EU perspective gives us also self-commitment. We are self-committed today to raise the standards of living, to raise the standards, the overall country development, which also the WHO report nicely shows this correlation between the more general contextual factors and the outcomes for healthcare workforce. So I would really like to say that today, my country, Moldova, is truly committed to do all that is reasonably possible to strengthen healthcare workforce and to support improvements in the performance of our healthcare systems.
Thank you very much, Svetlana. I think she's painted a very clear picture that is, of course, applicable also to a number of other small non-EU countries. And thank you very much for joining us and for sharing your highlights. Very briefly, Chris, can you take us outside the room again and tell us a little bit what people are thinking, what questions perhaps or comments, reflections they may have?
Thank you, Natasha. again, a lot of comments coming through. 4 key themes. The recent pandemic, which is prescient and then still in our minds, and the growth of spread of new diseases such as monkeypox, makes the investment in education of health workers, all health workers, a priority. The second issue that was coming through quite clearly is we need to realise that doctor-centric policies still permeate across countries, including in some where practice outside of doctors is embedded in law. And there's a need to focus on, look at the opportunities to look at working across the professional boundaries and embed those in policies. That led into some comments around the role of digital health and use of telemedicine. This offers opportunities both to better allocate resources, but also to include and to give people better working conditions. And finally, a key theme from a number of people was limiting mobility for individual workers is untenable. You need to reduce the factors that push workers away from where they work now and look to ensure that mobility has real and mutual benefits across member states.
Thank you very much for that summary, Chris. And I'm sure that there are a number of people in the room who have reflections on what they've heard from the panel. So once again, I hand over to Josep.
Yes, why didn't I get more votes on planning and forecasting? If there is mobility, why are we not planning and forecasting together? I don't want to reduce mobility, of course. That was just triggering some debate. But we should monitor mobility much better. And we may wish to adopt the code of practice of the WHO, which is very innovative, which does allow mobility, but puts a series of schemes in place to actually compensate from the wrong side of mobility, because there's a lot of positive side in mobility. I'll ask Matthias to talk about that in a minute. So, but from the room, the 3 people that voted for the last 2, can I hear them? The ones who want more health works planning, there you are, democracy for you. The ones that, can I hear them? Okay, can I hear anybody about their favorite policy and how to implement it? Can I hear anybody about anything? Good, thank you, Gemma, thank you, I love you.
So I'll confess to being one of the ones that voted for the bottom 2.
Good.
So
you work for the Observatory.
So especially the workforce planning and forecasting. I mean, I think this is critical going forward. Perhaps some people didn't vote for it because it's not even done at the national level. So maybe going to the EU level might be a step too far, because simply at the moment for lots of countries, just don't have the data. Even for the regional level, local level, we don't have any data. So then to start to implement EU-wide planning at the moment is challenging. But if we think of it as a priority, it might help countries strengthen their own sort of national monitoring systems. And I'm
tired of data. We all ask for more data. I agree. Isn't it political will? Why education and health don't come together and talk with each other and plan together? Because the health system wants certain types of professionals, and as medical schools keep training the same individuals, which are controlled often by these doctors here in the room, Not in the room, but doctors in the countries.
Yeah, it's an excellent question, and it's something that is key. And I think if you watch this space, there might be work coming out in that area of how we sort of can better align education and health policies. And I think people are recognising that it's going to be key to going forward, because you can't put the right professionals in place with the right skills to meet population health needs unless education and health work together. And at the moment, for some countries, the education, they train workers up to export them to make money, but that's not necessarily going to help the health sector in their country. And yeah, there does need to be lots of talking, but not just within countries, but across the EU as well. And I think that's why these joint actions and planning forecasting will come into play.
And accept that sometimes we're training professionals for the neighbor country, so we may as well accept it. Austrians, do you train many professionals from Germany, for instance, I believe?
Yeah.
Are you happy about that? Because it's paid with your taxes.
Yeah, it's a bit tricky, but the thing is, for Germany, the quantity is actually irrelevant in a sense, and for Austria, it's a huge issue. So the big countries really have some responsibility in this respect, and I think actually that the fact that we do not do these forecasting and planning exercises in every European Union member state is actually an opportunity for the EU to come in, and what we learned as well
I mean, actually, it's some kind of, I would say, market failure when it comes to the allocation of health workers, and therefore we need regulation, and we need regulation in all terms. It's not feasible if one European Union member state starts regulating, so we need these European regulation mechanisms.
Absolutely, thank you very much. Is there one final point before I go back to our, yes?
Thanks very much. To build on the comments about including non-EU countries such as Moldova, I would actually build on that and saying, let's also include other continents like Africa, because let's be honest, Europe, the European health workforce is built on also African workforces. So I think we need to address this and work together around this. Thanks.
That's absolutely perfect. Thank you very much indeed. So I'll go back to our panelists for some final reflections. I'll leave Hans for then, but maybe on the broader European region, indeed, because that's affecting the whole region. May I start with you, Svetlana, maybe to say, one of those list of things that you put together, what would you wish list in terms of the mobility, of the controlling of, or not controlling, regulating, monitoring mobility, and what the kinds of support, very briefly though, you would expect from neighbor EU countries for Moldova?
Well, we would support that all programs, interventions, and support would allow to result and to generate mutual benefits, to make sure that all countries, including the one that currently are the source countries for health care workforce, gain this mutual benefit and build on the collective benefit for the countries. And for this, everyone should be included.
So you can have a win-win, right?
Right, absolutely.
But yes, can you have a win-win really in this area? I mean, you've been looking for years, remember times of the Hungarian presidency in which we participated of the EU looking at some of this mobility and so on. And you looked at the code of practice as well. What are the kinds of strategies there, very briefly?
I'm not sure about the win-win, but we can certainly do better because there are a lot of trade-offs, and the trade-offs are between patients, professionals, and systems, regardless of which country they come. So we need to find a way to have a vibrant labor market that is really serving for all and mitigate the problems it creates. And number one, and that's maybe a little bit the elephant in the room, we need some sort of self-sufficiency to the extent it is possible. At least the large member states need to think about self-sufficient health workforce production, because even if they have only just 5% gap, for smaller, less affluent member states, it's really very difficult.
Can we shame them? Name and shame? Or can we regulate them?
No, I wouldn't do this, and it's also not necessary, because very often a receiving country is at the same time a sending country. You know, so they pass through, but probably they receive the wrong professionals and they send the wrong professionals.
To the US.
So we still have issues like, for example, better organizing our training and training slots, specialist training slots. Many people from countries go to other countries for specialist training because they can't get the slot. But they go in a way that they get stuck in the country. You know, they get stuck in the country and they don't return. So we need to organize training cycles where they really forced to return to their country of origin and don't get lost.
More than forcing, making it attractive as well. No?
Attractive. That's the word I was looking for. Thank you.
Yeah, pleasure. Isabel, they want you to do planning and forecasting. The room is very clear. Even if I didn't vote that, the room is very clear, and clearly the outside the room is very clear. What do you think? Could you do more on that? Because it's been said, Hervik was telling that to us, that if member states are not doing it, I know the subsidiarity, maybe you should do it. What do you think?
We can, I mean, to do the theoretical exercise of planning and forecasting, well, we have one basic problem, that is that we are planning with the data of today for something that will take 12 years. So it's 6 years or 7 of basic training, plus the specialists, 3, 4, 5 years. For doctors, 3 to 5 years for nurses. So maybe when we have finalized the exercise, or in 12 years, it's not useful anymore. This is a practical problem. Then, I mean, we could do the theoretical exercise of planning and forecasting, but member states don't follow. We have nothing to do. Someone was talking about the regulation of mobility that goes against the free movement of professionals. That is one of the pillars of the European Union. So it's of no use to begin to discuss if we can forbid, regulate, made a European Union regulation on mobility of health professionals. No, it makes no sense. Moldova is now a candidate to the European Union, so you will enter in this free mobility of the professional. What we can do is to support the member states to try to retain the health workforce and to offer better conditions. This is what we are doing with the Recovery and Resilience Facility. At the beginning of during the pandemic in 2020, all the member states, the 27, received the country-specific recommendations about the health system. And in 2022, 8 member states have received country-specific recommendations saying that they need to do something about their health system that they were not doing in the best way, let's say like that. And in the recovery and resilience plans that we have already adopted 26 positive assessment, and most of the member states have introduced something about the healthcare professionals related to the healthcare system. So incentives to the health professionals to stay in the country because they are offering better conditions is something that we are already doing. And I think that at this moment, jointly with the training, skill pact for skills and other activities, the joint action heroes, the different activities under the EU for Health program, and other is the best that we can do. But entering into regulation is something that leads nowhere.
Indeed, indeed. Thank you very much, Giselle. And from the EU to the Regional Director of WHO, Hans Kluge, you take care of the whole region, Hans. You don't have much regulation power, but you provide a lot. Now with the treaty, actually, get quite regulation power, but you take care of supporting these member states. You put many of the policies. You lead a lot of the thinking. What is your reaction on this whole mobility issue, perhaps? And also considering the South as well, Africa.
Yes. I see an enormous opportunity to raise the political commitment because these are discussions, Josep, that we all had quite a while ago. I remember a fantastic workshop we did maybe 10 years ago in the Netherlands, 3 regional. And there were trilateral agreements with the Philippines and with India, and we came together. And it comes back to what you told, the WHO Global Code on the ethical recruitment. I think it's a great set of principles. So it's a global issue. Number 1 is global. Number 2, it's local as too. Remember, we did this workshop together for a previous Minister of Health, Matthias too, of Belgium, with Dr. Maggie de Blok, on Belgium. And you have numerous clauses in Flanders, but you don't have numerous clauses in Wallonia. And then they could not refuse students from Netherlands and Germany, right? It was like, called it reverse discrimination. So you have to have it globally, but you need to have good in-depth knowledge also to contextualize. Point number 3, I agree that we need to decrease the administration because this is very, very frustrating for the health workforce. Now you see, I see it with my parents as well, you have very bright young graduates from business schools basically bossing the clinicians around as top of the hospitals, while previously, it was a bit too much also, no? I mean, a doctor could do whatever. This is also not. We have to work on the quality of care and some kind of standardization. But my point, I guess, is for common sense to come back. And then I really would like to express my admiration, appreciation to the Minister of Health of Moldova. I think it's doing, really great things. I enjoyed a lot what's happening over there. And absolutely, we need to embrace Moldova and the other countries. And I know that the Observatory and WHO Euro is ready to do its share together with the European Union, the European Commission. So I think there is an optimistic path forward, but we will need a lot of determination. Thank you.
Thank you very much. Determination and politics. Natasha, you want to conclude us?
I think we can just really wrap up again. I think this was a session that dug a bit beneath the surface, and it's definitely what we have to do in this area. It's not just about terminology, but it's really understanding that there are people behind this and trying to get this to a situation where, I think, Matthias, your point, we need to look at the numbers, we need to look at the demography, we need to see how the European region can produce what it needs and what it anticipates that it is going to need. If we produce, as Isabel said, what we think we need today, we are already off the mark. So it's about looking at epidemiology, looking at demography, looking at technology, and looking at the workforce together. Needs a bit of a more systemic perspective, which is why we link service delivery and the workforce together all the time. I think what I would like to end on is that at the moment the health workforce is, of course, highly feminized. Anything that we do also to improve the quality of life, work-life balance, and opportunities for the health workforce, indirectly we are also contributing to SDG number 5, and we are improving the lives of hundreds of thousands, millions of women across our region. We count on you to continue to work with us. The solutions are not easy, so I don't think we should come out and think that we have the solutions. And I don't think that just talking, about skill mix or digitalization, we really need to go far, far beyond and far beneath. But we are talking. Our report has shown a light, and we now need all hands on decks to help us to ensure that we get these messages where we need them most, in the middle levels in each country, in this pluralistic system of shared decision-making, which is where we have to operate. Thank you very much for joining us, and don't miss our plenary session on the perma crisis.
Indeed.
Thank you, Giuseppe.
Thank you.